Thank you, dear professor. I am delighted to share a dermoscopic study from the Dermatology Department of Ibn Sina Hospital of Rabat. Dermoscopy of rosacea, a comparative study between dark and light phototypes. Rosacea is a chronic inflammatory condition that manifests with various signs, including erythema, telangiectasias, papules, and pustules that mostly affects cheeks, chin, nose, and the central forehead. It's a continuous spectrum that includes different subtypes: erythematotelangiectasic, papulopustular, and phema. This condition is uncommonly described in patients with dark phototypes. This study aimed to describe dermoscopic features of rosacea in dark phototypes and compare them to those of light ones. We will also emphasize the major role of the dermoscope in increasing diagnosis accuracy of rosacea in dark-skinned patients. It's a cross-sectional descriptive and analytic study including dark and fair-skinned patients with a clinical diagnosis of rosacea. This study was conducted over a period of 4 years, from December 2020 to March 2024. Data was entered using Excel software and analyzed using Jamovi version 2.3. 206 patients were included in the study. The mean age was 45.8 years old. The majority of the population studied were women with a sex ratio of 6.6. More than 2/3 of the studied population had a dark phototype. We compared through this study the characteristics of rosacea in dark and light phototypes. In both of them, women were predominant, and the mean age was significantly higher in dark phototypes. Concerning the subtypes, 84% of dark phototypes had erythematotelangiectasic rosacea, while 52% in light-skinned patients. 12% of dark phototypes had papulopustular subtype, and up to 45% of light ones. Only 4% of patients with skin of color had phema, and 3% of fair skin color. There was a significant association between the phototype and both subtypes, the erythematotelangiectasic and papulopustular. 39% of dark phototypes had no visible erythema clinically, but the dermoscopy revealed vascular patterns with linear branched vessels and curved vessels. Concerning dermoscopy, pigmented areas were predominantly seen in dark phototypes, and orange structureless areas and crusts were predominantly seen in light phototypes. We found a statistically significant association between the phototype and pigmented areas, orange structureless areas, and crusts. On the other hand, we didn't find statistically significant association between the phototype and the following dermoscopic signs: polygonal vessels, linear branched and curved vessels, hairpin vessels, dotted vessels, and coma-like vessels. We had perifollicular pigmentation, scales. Demodex cells were seen as white protruding material projecting out of hair follicles. 13.8% of dark phototypes presented pustules non-visible clinically with a significant association. In phema, we found follicular yellow clots, rosettes, and linear vessels. We had more vascular patterns in the erythematotelangiectasic rosacea and more follicular patterns while progressing to papulopustular and phema. Our study is the first to describe dermoscopy between dark and light phototypes. We found that dark-skinned patients were older, that pigmented areas and pustules were significantly associated with dark phototypes. However, vascular patterns were not associated. Very few articles have described rosacea in dark-skinned patients, and the exact pathogenesis is still unclear. A genetic component, UV exposure, and neurological dysfunction all play a role. Pathogenesis of rosacea primarily involves skin barrier and vascular alterations, leading to more superficial blood vessels. Dermoscopy helps in the visualization and description of these vessels and scales that may be difficult to recognize with the naked eye. Clinically, in dark phototypes, erythema and pustules are often difficult to be seen, leading to diagnosis difficulties. Dermoscopy has gained popularity in those patients. In fact, patterns may significantly vary, because we have, first of all, a darker background, which may change some dermoscopic features. We have also some reaction patterns, which are more common in dark skin. For example, a higher tendency for pigment lability, which is responsible for a higher prevalence of pigmented areas, more follicular reactions, and more commonly sclerotic reactions. Articles on dark phototypes included a very few number of patients, 1 for Shabshub and al., and 11 for Erichetti and al. Larger studies were conducted only on light phototypes. Our study has the largest sample of patients with both phototypes and including all of the subtypes. In all studies, vascular patterns were predominant. Some particularities were seen in dark phototype, such as perifollicular pigmentation and pigmented areas in our study. We had a large sample of patients, including both phototypes, with significant results. However, our study is monocentric. Some patients have already started the treatment, and the follow-up is still going on. In conclusion, rosacea in dark phototypes is common in our context. Our study showed a remarkable variability between phototypes. Dermoscopy allows us to visualize vessels, facilitates the recognition of the clinical subtypes in order to guide the treatments. Thank you for your attention.